Hello guys, this is Muhammad Usama. So today, as you can see, we are going to discuss a topic from respiratory pathology, and this is bronchial asthma. So in this video, we will cover the pathophysiology of bronchial asthma. As you can see, this is pathology book. So we will cover pathophysiology and also we will touch the clinical section. So by the end of this video, you will have a good understanding of pathophysiology as well as clinics of bronchial asthma. So without any further ado, let's start. What is bronchial asthma? So it is basically reversible airway bronchoconstriction. As you can see in the book, it is reversible airway bronchoconstriction most often due to allergic stimuli. It says atopic asthma. So what does it mean? Basically, as you know, that we have the terminal portion of our lungs, or let's say the functional portion of our lungs, which is alveoli. Okay, these are the functional portion of our lungs. And what is the function of alveoli? Basically, gaseous exchange, which is the exchange of carbon dioxide and oxygen, that is taking place in alveoli. So that is why we call that functional unit of our lungs. Okay, but alveoli, how do they get air? Of course, there are airways, passageways, okay, which of course through multiple division they lead to alveoli. So if this is the alveoli, these airways or these channels or these canals which lead the air towards this alveoli, these are called bronchioles. Okay, these are called bronchioles. And anything which constrict these bronchioles, okay, which constrict these bronchioles, which make these bronchioles narrow, that is going to produce shortness of breath in the patients, of course. So you all understand, right? So as far as asthma is concerned, as it is basically problem of this portion, not this. This is the alveoli. Asthma is not related to alveoli. It is related to the problem in these bronchioles. So what happens is that these bronchioles undergo inappropriate type of bronchoconstriction. Okay, they undergo inappropriate type of bronchoconstriction. So now, what is the cause of bronchoconstriction? So 95% of the times, 95% of the times, the cause for this bronchoconstriction is allergy. What is this? Allergy. Allergic reaction, or let's simply say hypersensitivity reaction. Okay. So any sort of asthma or any sort of bronchoconstriction which is related to allergy, that comes under the category of a triad called atopic triad. Atopic triad. So what is atopic triad? Basically, it is, so what is triad? You all know what is triad. Triad is any clinical disease or anything which has three features. Okay, three features. What are three features of atopic triad? So number one, eczema, body rash. It simply means body rash. Number two, rhinitis. And number three, atopy or bronchoconstriction. So when I say atopic triad, I mean these three symptoms occurring together. So for the atopic triad to be present, these three symptoms should occur together. Okay. For example, if someone goes out in let's say in a very bad weather and he comes home, when he comes home, he has body rash. Okay. He has this rhinitis which manifests in the form of nasal congestion. Okay, and he has this bronchoconstriction. So suppose an 8-year-old or 10-year-old child goes out to play in a very bad weather, and when he comes home, he is having rashes on the body. Okay, he is having nasal congestion, and he is having very difficult time in breathing. He cannot breathe. He complains his mother that I cannot breathe, I'm having very difficult time breathing. That is called bronchoconstriction. So if all these symptoms are occurring together, that is called atopic triad. Okay. Okay, so those patients who develop this atopic asthma or bronchial asthma, which is related to allergy, they develop this in childhood. Okay, this is very important thing to remember. They develop this in childhood. Okay, because we have other types of asthma which are non-atopic asthma, which can be like infection related asthma or exercise induced asthma. Those type of asthma, they develop later in life due to some underlying cause. For example, underlying cause can be exercise, vigorous exercise. Underlying cause can be some sort of severe infection, right? But this atopic asthma has to develop in childhood. 95% of the times atopic asthma or atopicity develops in childhood. So why it develops in childhood? Because these children who develop this sort of atopicity, they have some genetic susceptibility. They have some genetic susceptibility. They have some genetic susceptibility. What does it mean by genetic susceptibility to have this bronchial asthma or to have this atopicity? It means that in these children, they have some sort of genetical modification which lead to bronchoconstriction when exposed to some allergen. Okay, so for example, what is that genetic susceptibility? That genetic susceptibility is an inappropriate type of reaction of the body to some foreign antigen. Okay, to some foreign antigen. And what is that antigen in this specific case? In this specific case, that antigen is allergen. Like, right, allergen, for example, pollen grains. Okay, pollen grains, because many people who are atopic, they have this allergy to pollen grains, and when the season of pollination arrives, they prefer to stay at home. They do not want to go outside because they know if they go outside, they will have that bronchoconstriction, they will have that asthma attack. So most of the times it's pollen grains, but it can be any allergen, right? Chemical allergens or any allergen, for example, dust. Okay, so these kind of things are they serve the purpose of antigen for this inappropriate type of reaction to happen. Okay, now let's go on to details of what exactly is this inappropriate type of reaction which leads to this atopicity. Okay, which leads to this airway bronchoconstriction. What exactly is that reaction? Okay, now what happens is that, as we know, that when a person inhales an allergen, for example, he inhales a pollen grain. Okay, a pollen. Okay, so normally what happens is that we have macrophages. Okay, macrophages, which are also called antigen presenting cells. Okay, antigen presenting cells. These macrophages, let's say, take up the pollen. So this is a pollen, for example, and this is a macrophage. So this when this pollen grain is inhaled in our body, it will be taken up by this macrophage, and this macrophage will take this pollen grain. For example, it has taken it up. Okay, it has taken it up. Now it will take this pollen grain and it will send it to specific immune cells in our body. What is that immune cell? That is called T helper 2 cells. Okay, these are basically T lymphocytes. Okay, T lymphocytes, and they are helper in nature, and they are what category? T helper 2 category. T helper 2 lymphocytes. So we have many different type of lymphocytes. For example, T helper 1 cells, T helper 2 cells, natural killer cells, cytotoxic cells. So these are all the types of T lymphocytes. And here in this specific case of bronchial asthma, we have T helper 2 cells which are coming into play. So in a pollen grain enter into our body by inhalation, it is taken up by the macrophage. Macrophage takes this pollen grain and give it to what? T helper 2 cell. Now this T helper 2 cell does what? When it gets this pollen exposure, so this is a pollen grain, and when it gets exposure, this T helper 2 cell undergoes a reaction, right? Undergoes a reaction, and it starts producing interleukins like interleukin 4, interleukin 5. Now point to remember here is that normally we healthy normal individuals, we are also exposed to these type of pollens, right? When we go out in a pollination season or any any area where there are some sort of allergen which can induce bronchospasm in atopic individuals, normally when we go out, we are also exposed to these pollens. Okay, we are also exposed to these allergens, but our T helper cells do not undergo this reaction. Our T helper cells, they do not produce these interleukins, okay, upon getting exposed by these pollens, right? But in these individuals have genetic susceptibility for their T helper 2 cells to undergo this type of reaction and produce these interleukins, right? So normally what I say, that we normal individuals do not produce these interleukins when we are exposed to these pollens, okay? But these individuals with atopicity, these individuals with atopic triad, they have some genetic susceptibility that their T cells immediately undergo this type of inappropriate reaction and start producing interleukin 4 and interleukin 5, okay? So now these interleukin 4 and interleukin 5 are the major mediators which play a role in the pathogenesis of bronchial asthma. So what actually happens is that, let's start from the book, what book says, okay? So my book says that allergens induce T helper 2 cells, okay? And here I have drawn a little note that as a result, these T helper 2 cell undergo inappropriate type of reaction and produce interleukin 4 and interleukin 5. So what happens basically is that interleukin 4 acts on the plasma cells and cause the plasma cells to produce antibodies, okay? So now this interleukin 4, it will stimulate this is B lymphocyte, okay? This is what? B lymphocyte. This interleukin 4 will stimulate this B lymphocyte. When it will stimulate this B lymphocyte will be activated. It will be activated, and this activated B lymphocyte is called plasma cell. Activated B lymphocyte is called plasma cell. So these plasma cell, after being activated by interleukin 4, will start producing antibody, okay? Will start producing what? Antibody. This is antibody. These are what? Antibodies that are produced by B lymphocytes when B lymphocyte was stimulated by interleukin 4. And how interleukin 4 was produced? Interleukin 4 was produced by T helper 2 cell. And how T helper 2 cell produced interleukin 4? Upon exposure by some pollen grain or some allergen. That is simple, right? Now what does this antibody do? Okay, this antibody goes on and get attached to mast cell. So this is mast cell. Now you all must know, by if you're watching this video, you all must know what is mast cell, because these are the topics from basic pathology, right? From the very beginning of pathology, you all know what is mast cell, okay? This antibody attaches itself to mast cells, okay? This is antibody attachment to mast cell. So what happens is that this is kind of a memory, right? What kind of memory? So now this was initial exposure, okay? This was initial exposure. Up till now, we do not have any symptoms. Up till this procedure, antibodies being attached to mast cells, we do not have any type of symptoms. But now if the same person, if the same person is exposed to this allergen again, okay, if this same person is exposed to this allergen again, now after exposure, these antigen will come directly and bind on to these antibodies, which were produced by initial reaction, okay? So these antibodies were produced initially, right? And now when this person is exposed to that allergen or pollen again, that pollen will come and bind on to already produced antibody which are attached to mast cell. What happens when antibody are attached with this foreign antigen that comes again in the body? An inappropriate type of reaction happens. What is that inappropriate reaction? When this happens is that these mast cells degranulate. So in simpler terms, we say that when allergen comes in the body next again, okay, after initial exposure, when allergen comes in the body again, we can say second exposure, it attaches itself to these antibodies which are attached to the mast cells, and because of this reaction, antigen antibody reaction, these mast cells degranulate. Degranulate means these mast cells have specific granules in them, okay, specific granules in them. These granules are thrown out. And these granules contain histamine. What these granules contain? These granules contain histamine. These granules contain leukotrienes, okay? So you might all know what is histamine, what is leukotriene, because if you are watching this video, it must be that you have already gone through initial chapters of pathology which gives you a basic understanding of what is histamine, what is leukotrienes. Basically, these are the chemical mediators which undergo, which help the people to undergo vasoconstriction when they get bleeding, okay, which cause vasoconstriction when as people get infected, okay. So these type of chemical mediators which play a very important role in inflammation in our body. So these mast cell produce histamine and leukotrienes after this type of reaction. Now, what does this histamine do? This histamine is a potent bronchoconstrictor. This histamine is a potent bronchoconstrictor, means when our bronchioles are exposed to this histamine, our bronchioles immediately contract. Our bronchioles immediately constrict, they become narrow. So bronchiole become narrow after being exposed to histamine and after being exposed to leukotrienes. All right, so this is how bronchoconstriction takes place. So let me just recap. So let's just recap what happens that first of all, allergen enters into the body. That allergen was taken up by the antigen presenting cell, which was macrophage. That antigen presenting cell took that allergen and presented it to T helper 2 cell. Now T helper 2 cell in these genetically susceptible individuals will undergo inappropriate type of reaction to produce interleukins like interleukin 4 and interleukin 5. Now this interleukin 4 has a very important function in the pathogenesis of bronchial asthma, that it will activate B lymphocytes. When B lymphocytes are activated, they will become plasma cell, and these plasma cell will start producing antibodies, okay. Now these antibodies will go and attach themselves to the mast cells, okay, and those mast cells, basically those mast cells are the cells of inflammation, okay. When antibody attached to the mast cells, now next time when the same allergen comes in our body, the second exposure, those allergen will attach themselves to the antibodies which are on the mast cells, okay. Because of this antigen antibody reaction, these mast cell will degranulate. When they will degranulate, they will produce these what? Histamine and leukotrienes. And histamine and leukotrienes are what? They are potent bronchoconstrictors. That's simple, right? All right, so this was related with interleukin 4 mediated process. Now, there was another interleukin which was also being produced by that T helper 2 cell, and that was interleukin 5. What does this interleukin 5 do? Interleukin 5 is there for some purpose, of course. If it is being produced, there must be a purpose, right? So what is the purpose of interleukin 5? So basically, let me just draw here. Okay, interleukin 5 is a chemotactic agent. Chemotactic agent. Okay, what does it do? It attracts an other type of white blood cells in our body. These are called eosinophils. Interleukin 5, which were produced by that inappropriate reaction of T helper 2 cell, it is a chemotactic agent. It will start attracting eosinophils, okay. When it will start calling eosinophils to the site, and these eosinophils will become activated by the action of this interleukin 5. These activated eosinophil will start producing leukotrienes, okay. Leukotrienes, for example, they will produce leukotriene C4, leukotriene D4, and leukotriene E4, okay. So these type of leukotrienes are being produced by this eosinophil. And who called eosinophil? Interleukin 5. And who produced interleukin 5? Of course, T helper 2 cell, right? Remember, if you remember from the previous section, okay. So these leukotrienes which are being produced, they are also bronchoconstrictor. They are also what? Bronchoconstrictors. So up till now we have discussed three potent bronchoconstrictors. Number one, histamine, which was being produced. Number two, leukotrienes, which were being produced from the mast cells. And here, leukotrienes produced from the eosinophils, okay. All right, so that was the pathogenesis of bronchial asthma. There was another interleukin which was being produced by the T helper 2 cells, and that was interleukin 5, okay. What does this do? What does this interleukin do? Because if it is being produced by the T helper 2 cell, it means it must have a specific function in the pathogenesis of bronchial asthma. And what is that function? Basically, interleukin 5 is a chemotactic agent. It is a chemotactic agent, right? You all know what is chemotaxis, when some chemical mediated signaling calls some cells to some site, that is called chemotaxis, right? So interleukin 5 is a chemotactic agent. It attracts eosinophils. It attracts eosinophils, and these eosinophils, after being invited by interleukin 5, will start producing leukotrienes. Specific leukotrienes which are being produced are leukotriene C4, leukotriene D4, and leukotriene E4. Okay, so these leukotrienes are bronchoconstrictors. Remember, these leukotrienes are bronchoconstrictors. Up till now, we have discussed two potent bronchoconstrictors. Number one, histamine. Okay, in the previous slide, we talked about histamine, that it was being produced by the mast cells, and here in this slide we are talking about leukotrienes. Okay, leukotrienes. So both of these have function for what? Bronchoconstriction. Okay, bronchoconstriction, right? So that was about pathogenesis of bronchial asthma. Now let's just talk about the clinical features. What are the clinical features? I think I'll have to go to the book, because in book it's written in very good details. Okay, what we have to know, all of that is written in the book. Okay, so this portion we have discussed already, we have covered already in the video. This was pathogenesis related topic. Okay, now we will see the clinical features. Clinical features are episodic and related to allergen exposure. It means that these asthmatic individuals will not have bronchoconstriction all the time. They will not be asthmatic all the time. They will become symptomatic only when they are exposed to allergen. Okay, when they are exposed to allergen, only then they will become bronchoconstrictive. Okay, so what are the clinical features? Dyspnea and wheezing. Dyspnea and wheezing. Dyspnea is shortness of breath, which is a general term. You all know that, right? But wheezing is something it is seen specifically in bronchial asthma, but it's not only associated with bronchial asthma. So if someone has wheezing, do not always suspect that he must have bronchial asthma. Wheezing can also be associated with many other factors, but 100% of the times, almost all the time, wheezing will be associated with bronchial asthma also, right? So let's just not confuse it. Okay, dyspnea and wheezing. Productive cough, that's very important. The cough will be productive, means sputum will be there. Okay, classically with spiral shaped mucus plugs. This is very important phenomena, and that comes on examination also. This is a very high yield point, that these type of mucus which is produced will be spiral shape, and this is called Kirschmann spirals. We have the name for these spirals which are produced as a part of productive coughing, right? We have the name. That name is Kirschmann spirals, and eosinophil derived crystals called Charcot-Leyden crystals. So this is a bit from histology. Okay, if you should remember this name, Kirschmann spirals and Charcot-Leyden crystals, because most often they come on examination also, right? So eosinophil derived crystal, Charcot-Leyden. Severe unrelenting attack can result in status asthmaticus and death. Okay, so if a patient who is becoming asthmatic, okay, who is having symptoms and severe symptoms and are not managed promptly, that can result in a condition called status asthmaticus, and status asthmaticus is a very, very severe condition. It can lead to death. When someone presents with status asthmaticus, it means this is a medical emergency. So clinical features include dyspnea, shortness of breath, of course, wheezing, productive cough, and in productive cough we will observe what? Spiral shaped mucus plugs. These are called Kirschmann spirals. Okay, and we'll also observe eosinophilic derived crystals called Charcot-Leyden crystals or Charcot-Leyden crystals, whatever you want to call it. Okay, so these are what you will see on if you histologically observe those mucus plugs, those sputum. Okay, and now, asthma may also arise from non-allergic causes. As you can see, it says that asthma may also arise from non-allergic causes, and they do not have any understood mechanism of how non-allergic asthma comes into play. There is no specific understood mechanism as of now, but you should know that that is called a non-atopic asthma, and it can be induced from exercise, it can be induced from viral infection, and it can also be induced from aspirin. Okay, aspirin intolerant asthma. Okay, and occupational exposure. Okay, occupational exposure, for example, those who work in the coal mines or who work in the construction department, okay, they are exposed to different type of chemicals over and over and over again, which lead to asthma. Okay, these are all non-atopic type of asthma, because atopic asthma is something which develops in childhood, as I spoken earlier. It develops in childhood, okay, and non-atopic asthma, it's very commonly develops later in life. And for as far as atopic asthma goes, right, there are some very rare cases in which atopicity can develop later in life also, but almost almost all the times atopicity develops in childhood. So that's what you have to remember. Okay, so let's just finish off this pathophysiology section with one very important thing, that is aspirin related asthma or aspirin intolerance asthma. What is aspirin intolerance asthma? Okay, so aspirin, as you all know from pharmacology, that this is a drug that is given as blood thinner. Okay, it is a blood thinner. It prevents clotting. Okay, it prevents blood clotting. Okay, so we give it mostly after heart attack and after myocardial infarction, where we do not want the clots to form again in those coronary vessels. Okay, we give many different kind of blood thinners, and aspirin is one of those blood thinners. Okay, so how do patients get aspirin intolerant asthma? Okay, so this is also something of genetic nature, because not all individuals are aspirin intolerant. Okay, not all individuals are aspirin intolerant. Then who are aspirin intolerant? That's a big question, right? If not all the individuals are aspirin intolerant, then who are aspirin intolerant? So basically, aspirin intolerant asthma is seen in those individuals who have something called Samter's triad. Okay, Samter's triad. What is Samter's triad? So if any individual who is having nasal polyps, okay, who is having nasal polyps, okay, who is having asthma after consuming non-steroidal anti-inflammatory drugs or after consuming aspirin, okay, and bronchoconstriction. If someone is having these three things together, nasal polyps, asthma after non-steroidal anti-inflammatory drugs or aspirin, and bronchoconstriction, if someone presents with these three symptoms together, that is Samter's triad. Okay, so it also is a genetical susceptibility, right? So those individuals with this sort of Samter's triad are called aspirin intolerant individuals, and when they consume aspirin, they get bronchoconstriction, and we call that aspirin intolerant asthma, right?